If those that are in their life that are healthy are coming at them from that stages of change we quickly went through, if they're coming at it the wrong way, they're going to push them away. Inability to engage in behaviors that might assist detachment. Oftentimes, survivors of abuse will say, I would rather be hit than left alone and isolated from him. Because the idea of being left alone is so overwhelming and lonely and fearful, they would rather incur the violence. So anything that could cause detachment from these guys, and these guys are really good at making sure the full dependence is on them, the loyalty is to them. They may not, we have multiple women that never even knew how to get identification. They don't know how to get their own hotel room. They don't know how to get a bus pass. They don't do anything for themselves. They keep them dependent without life skills to know how to survive without them. Inability to engage in behaviors that may assist their detachment. Sorry, and then the sad piece is they're just grateful he didn't kill them. They've got gratitude towards him, that they're still alive. Because the idea of the guilt and it's their fault says, I mean, he has the right to kill me over this. He has the right to beat me over this. Because that's the lens that is coming through. So the psychology of the trauma, you're going to see the PTSD, the Stockholm Syndrome, the complex trauma, the trauma bond. And it is going to sound like, I love him, screw you, he didn't make me do it, he just needs to get back on his feet. I told him I was 18. I just want to go home. I'll be good. And we want to believe him because sometimes it's just less of a fight, isn't it? And otherwise, you're going to go past your shift. Somebody else is going to have to figure this out. Who can we bring in? And sometimes it's just easier to let their argument win. And then we miss it. We miss an opportunity. We may not finish it, but I'm telling you, you plant a seed, it actually matters. And when they come to us, we hear the different seeds that have been planted in their lives and how it did matter. And when they go to somebody else, we may have been one of those. And we may never hear it, but we know it works and it matters. And we've heard it plenty of times. So that is my portion of the presentation. Caitlin, you're up.
Awesome.
Yep.
If anybody wants to get coffee or anything like that, it might take a little while to flip over. After the presentation with Melissa, how many people think that they've interacted with a human trafficking victim? Now keep your hands up. How many of you people knew that before the education? It's so important to have education for every single staff member, not only in the ER, but also in the hospital, because we are all human. And some people might see things from a different perspective than what we do in the ER, or vice versa. The question is, why healthcare? I think Melissa did an awesome job with the statistics, and I have the same ones. Up to 97% of patients that have been in the ER, which, as Melissa said, most survivors have stated they've been to the ER at least once, receive no information about where they can go, where they can get help. And up to 60% of this in other literature has said nobody's even asked them about their safety. So what can we do as a hospital to change this statistic? The first part is what you're doing today. You guys are in education. We're not going to know anything about what's going on in our community if we're not told or shown. So that's what you guys are here doing today. The next part is to create a plan. I hope you guys grab some of the referral pieces of paper, because that's our plan here at Northern Nevada. And I want to say a huge thank you to Awaken, as well as to CASA in the back, and all the other nonprofits that really helped me develop this program. And lastly, is to do a follow-through. I have no doubt that my staff members in the emergency department can identify these patients with just a little bit of education. What do we do then? we have a patient in the emergency department at 2 o'clock in the morning. It's a labor trafficking victim from Venezuela. Who are we going to call? What do we do if nobody's answering because they're not 24/7 resources out there? That piece we've slightly solved with the community partners that I've had, but it's going to be an ongoing process that I hope the community members that are in the room right now are willing to help. So if you guys will refer to the little algorithm I have. So at Northern Nevada, we have a two-step process for identifying these patients. I'm hoping that through education and this video that we have here today, that everybody will understand what red flags are. These are the patients that come in and they have a burnt passport. Do these patients have very suspect tattoos? Do they have a very controlling male or female with them? I'm not sure if Melissa touched on this, but a lot of the times the pimps will actually send in their top prostitute or recruiter with the patient that's coming in saying, oh, that's my sister. So it doesn't matter if it's a male or a female that's accompanying them to the emergency department. That's a risk. So what are those red flags? Is it a controlling female or male? Is it a tattoo? Is it poor dentation? That's extremely common in these patients because they have total neglect. They don't brush their teeth. They don't have resources. Are they extremely off-putting? Do they not know what city they're in? They might not have a phone number. All those are huge red flags. So from admitting to lab, to the nurses, to unit secretaries, it's all important for us to be aware of all these red flags. And that is the only job for 90% of the people here at Northern Nevada. Your job is to notify the red flag alert and let the charge nurse know. The second thing that we're doing here is a silent notification system. That's what these posters are going to be. These are going to be up in the patient bathrooms. These questions that are on here have been chosen by survivors of both sex trafficking and labor trafficking. They're extremely sensitive, and if any of these questions are answered yes by the patient in the bathroom, which a reminder, only patients are allowed into our restrooms. Everybody else is a family member, and this is extremely important for this protocol that they need to go out in the lobby and use that bathroom if they're a family member. But if they say yes to any of these questions on these flyers, they put a purple dot sticker on the bottom of their specimen cup, and they give it to a nurse or any other staff member because they will know that that purple sticker says, hey, I might be in need of help, and this gives them the ability to do that without alerting their trafficker that anything's going on. So if any staff member, including lab, I get to ask them, if any staff member sees that going on, then their job is to also alert the charge nurse.
If this patient doesn't need a urine specimen, is that something we could ask the doctor, we'd like you to order a UA, even though they're here for a cough, or something different, or like a wound? Can we ask that, because then they're not going to see that?
I think a good practice for any ER nurse is saying, I don't know if we have to get this UA or not, even a finger fracture, right? You're like, you have to pee now, let me get that pee because I don't know if you're going to be able to pee for the next 4 hours. You might be hanging out in the ER for the next 5 hours trying to pull that pee out. So as nurses, we're like, just give me the pee in the cup. And most patients that come in know that they have to do that. Otherwise, it could increase their length of stay. So I think for us as an ER, just get urine from everybody. You don't really have to send it down a lab.
Yeah.
Sometimes you just keep it, or we just put like a patient label on it. But if you notice that purple sticker, just grab it. Or they might even, they're on all the bathrooms, and we have urine cups in all of our bathrooms. So it could very well, they'll just put something on.
Are you gonna keep the stickers with the urine cups, or where are you gonna
Yes.
put them?
Mm-hmm. Yep. So all of these posters will be, so they're Spanish and English.
Mhm.
They're gonna be both be laminated in the bathrooms, and there's gonna be stickers and a little baggie underneath them.
Oh, okay.
Yeah. So these are the questions, and you guys have it in your handouts as well. So the top 3 questions are mainly for sex trafficking. These are our sex trafficking survivors that created those questions. And the last 3 are from our labor trafficking survivors. So who talks directly with the patient? It is not the expectation that we require everybody to have those questions ready and performed and ready to talk to these patients. It is not an easy conversation, and it's not going to be a script. These are going to be specially chosen charge nurses And that's why I asked other floors to come here, people who are strong in having difficult conversations. Part of that is called a trauma-informed communication style. I heard Melissa talk very much about the trauma bond, right? So these patients have severe levels of PTSD and they're traumatized. So how do we have conversations with these people? If anybody here has had a conversation with a trafficking victim, you might as well have been cussed at, told to go away, I'm going home, I don't want anything to do with you. It is going to be very difficult to have conversations with these patients, so it's important that specific individuals are in charge of having these conversations. So that's case management and people that I call nurse advocates. So these are people that me and Awaken are both going to work with over the next couple of weeks to get you used to having those conversations. And the best way to do that is role play. So it's going to be me and that nurse advocate having that conversation, me throwing some stuff at you and trying to figure out how do you respond to that. That's not an easy conversation, and it's not an expectation that everybody's going to thrive in that kind of a position. Also, it's important that there's no more than 2 people having this conversation. If somebody feels threatened, and you kind of come up with a force of 5 people, how would you feel? You'd feel attacked, and that's the last thing that we want our patients to feel. So for those of you that are in here, and I don't work directly with you, if you think that you're one of those people that have those qualities, and I'm looking at geropsych, that you have difficult conversations often and you feel comfortable with it, please come let me know. And I'll figure out a train schedule. You can either come over to my house and we'll work on it. So this is the big picture, right? We told our charge nurse, hey, I feel a gut instinct about this. I don't feel good about this. I think this might be one of those situations. Or, hey, I found a purple dot sticker. Every single one of my charge nurses is extremely strong. They can go and say, hey, I'm just doing leadership rounding. How are you doing? Can I get you a warm blanket? And you can assess the safety situation, right? So you go in there and you see that that patient has another person in the room. It's probably not safe to have that conversation in there. Is this patient have an x-ray ordered or a CT? Great, that's an awesome opportunity to bring that patient over to radiology. We even have a set spot in the ultrasound room. We're gonna go there and meet up with case management, and our nurse advocate's gonna be there. And we're gonna have that dialogue with them with the trauma-informed communication process. And then from there, I think this is the most important aspect of all, is the referral tree. I mentioned earlier, I have no doubt that our nurses are extremely strong, or our techs, or admitting clerks, that they can say, hey, I just don't feel good about this. You have the conversation. Now, if a patient says, no, I don't want your help, get away from me, we have to respect that, unless they're a minor. If they're a minor, we follow our mandated reporting protocols as healthcare workers. It's our job. We have to ensure the patient's safety, make sure they're comfortable, and make sure that that patient does not leave our site until we get them the proper safety. Now, if they're non-minors, we ask their permission. Can I give you resources? Are you in a situation that you need help right now? If they say yes, that's the easy part. Then we refer them to everything that they need. If they say no, that's hard as a healthcare worker when you know something's going on, right? So what can we do when they say no? Can I help you memorize the human trafficking hotline number? It's really, really easy. Can I give you a bracelet that's kind of secret, has like Awaken's little thing on here? Do you feel comfortable with me giving you that? Or hey, can I make a follow-up appointment for you in 3 days from now? It's legit documentation. It says here that you need to follow up in the ER in 3 days. And so if you decide that you do want help, you have a reason to come back to the ER, and we will be here to help you if you want it. There are avenues. So like I said, the easiest way to do things is calling the human trafficking hotline number. We call local law enforcement. There's emergent lines, which is 911, and non-emergent, which is the 2 things listed over here for Sparks and Reno. Typically, we're going to call Sparks if it's in our area. If the setting for the trafficking was in Reno, we usually call them first, but any law enforcement would just say, call us. For commercial sex exploitation, we're going to call Awakened, and they're awesome with their response times when they come in. Usually, the last time I called was like, I don't think a 30-minute turnaround, really fast.
What are the hours for a week?
Huh?
weekend have hours that you
So
respond?
we always have somebody on call 24/7, so for emergencies, not just for like, hey, what do y'all up to? But like, for emergencies, we will have somebody available.
And then for 2 CASA, they are mainly for labor trafficking. They do have set office hours. But then for 24 hours, the gospel mission is awesome. It's used for men and women to call them for support. And same with the crisis center. They're an awesome resource. Safe Embrace is for women, and they're open 24/7. And then the Nevada Urban Indians is also a great resource. Labor trafficking and sex trafficking, any kind of victim, they are open and willing to help. But they do have office hours from 6 to 5. So I just want to thank you all for being here.
I just had a question because when we look at sending people to shelters before, oftentimes there's a waiting list. Do they have beds set aside for trafficking victims?
So it depends. So I talked to Casa de Vida, which is for pregnant women. They said that if you call them in the middle of the night and you have a pregnant female, they 100% have a bed. Call them. Safe Embrace might be able to help, as well as the Eddie House for last minute beds. That is a huge part that I talk about all the time with Daisy. What do I do with my labor trafficking victim at 2 o'clock in the morning that's from Venezuela and doesn't speak English, right? So my hope, and it sounds like eventually as this program kind of progresses, there might be a task force in the community that actually focuses on that particular problem. That's the biggest question mark with any hospital implementing any algorithm for human trafficking.
Nicole, do you want to plug the fund?
And I just wanted to add.
Sure.
Oh yeah, Daisy, you want to go?
Well, I just wanted to add to what you had said, just so that everybody knows what resources we're working to connect to for victims. So the task force, there's the Alliance for Victims' Rights, and that's a task force that already exists in our community, a coalition that exists, and so we want to create a task force under them that would have all of the advocates and service providers already in one place, get together, figure out our resources, and maybe do some really strong partnerships where we could ask places like Safe Embrace and CAW or Domestic Violence Resource Center. We can ask them to hold a bed for specifically human and labor trafficking victims. We can write up MOUs. We can have that set so that nurses can have somewhere to refer to, and we've done that in the past with certain types of victims. They'll hold like a top bunk at all times, just in case somebody calls. So just so that you're assured that we are working on something that is more, because we know that as nurses, you're there in the hospital. I have cousins who are nurses, and they're like, we have nowhere to send you. Like, we don't have anywhere to send domestic violence victims, or, you know, it's like you said, 2, 3 in the morning. That can be a real challenge, and so we really want to help provide those services and resources and have that so that when we do have identified the victim, we as a community of advocates and service providers can meet their needs. And Nicole, sorry.
Sure, no problem. So my name is Nicole O'Banion. I'm the Ombudsman for Domestic Violence, Sexual Assault, and Human Trafficking at the Attorney General's Office. I'm just going to walk over here so I don't have people behind me, sorry. So Melissa had just wanted me to provide some information on the Human Trafficking Contingency Account that we have here in the state of Nevada. It was created in 2013 legislatively, but it wasn't funded. So it was created to be managed by the state and then was able to accept donations to the fund. The Attorney General's Office took it upon ourselves to hold a fundraiser every year. Up here in Reno will be the 6th annual fundraiser, and then we started the first one down in Vegas last year. So that account has been phenomenal in that it is funded by donations, so it doesn't have the same parameters as all of the other state and federal funding does. So we actually have the ability to use it for a variety of things that would normally be denied. So I'm just wanting to let you guys know that that money is out there if you run into any issues, travel issues, clothing issues, personal item issues, safety issues, anything like that. We do need to work with either nonprofits or agencies that are already set up with the controller's office. But I do have my business cards, and so either myself or Melissa would be the contacts if you're needing to access those funds or if you have any victims needing any sort of financial help. It's very fast, quick, easy money to mobilize, and so I'm just trying to get that word out there also. Thank you.
So we've been able to do that use it for hotel rooms, for emergency housing, that kind of stuff, when we can't find anything available, any type of placement like that. And then sometimes they just need to get out of state for their own safety, and so we've been able to use that to relocate them to other organizations around the country that are willing to do housing and programs. And so it's helped to pay for their emergency needs, their clothing, their whatever they don't have in those first few days that we have them, and then the airfare even to get them there. We've been able to get reimbursed for that. So that's some of the stuff that we can do in those crunch times.
That was the end of my presentation. Does anybody else have any questions?
So going back to your one where they said no, 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 and then they don't want the 3-day or anything like that, there's nothing else. I know it's like, there's nothing else you can do for them. There's no,
So there's no mandatory reporting in the state of Nevada. It's a HIPAA violation if we were to call somebody on them, because we as healthcare providers need to keep things to ourselves. Other states have passed legislation that allow you to report areas that you suspect that some type of human trafficking is happening. We don't have that. So for our facility and our protocol, if they say no, and they're not a minor, there's not really a lot that we can do at this point, except, like I said, can I help you memorize the human trafficking hotline number? Can I give you a kind of a concealed bracelet? Can I give you a follow-up appointment?
that's a hard gray area. I work at 3 different hospitals in this area. I see this all the time where I'm not, like I've had 5 that I can think of right now off the top of my head where I've seen someone where I feel like that's what's going on. That's the part, it's hard to get the one away or to talk to them and what to do. Like, yeah, we can see it, but how are we going, like, you know what I mean? If they don't want the help, or if there's no way, if we see it and we want to help them, how do we get them away to actually do it if we can't? Or we just let it go, or what's going to happen when we do?
We try our best, but I can tell you, working with this group, that is a very frustrating piece, is that if they say no, that we have to respect their autonomy.
We'll still show up though.
Yeah.
Yeah, like, can I still call you?
But I can.
Yeah, that's still a HIPAA
We'll
problem
still show
if I
up.
still call you. Like,
There
I've
are
seen it here at
ways to
Northern
ask the
Tribes.
question. We have learned to just say, do you want to talk to a community provider in case you got any needs? And it doesn't have to be about that up front. And that you might want to delete that part. But I'm just telling you, there's been ways where we've been able to get a meeting. They're fine with it. It doesn't end up having an adverse effect at all. And then they can say no to us, but then they remember us or whatever that community
And if
provider
they're so
is.
drugged up on whatever someone gave them prior to coming in,
We've done that before too, and we come back every single day. And eventually they sober up. And we're still there.
right?
Yeah.
Because they're not even like having good conversation because I don't know what was given prior.
And then we've seen it go through the whole thing where then they sober up and then they're willing to go to the next phase of treatment or behavioral place, and then I'm gonna go back. I mean, and then we also see where they don't go back. And so it's kind of the risk we're willing to take every single time.
And then
Since
coming
it's not
in and
illegal,
out.
we can't call these guys or anything else because.
Yeah, so that's why we're gonna train nurse advocates to have those conversations, because it's gonna be specific role play. Let me get this chipped into your head about the specific things that you can and cannot say as a healthcare provider. And that's why they're so instrumental in this. Travis?
No, it's kind of like addicts. The most effective intervention is just multiple referrals and offering of resources. So confrontation with these folks, or any sort of even bringing security guard or pushing the issue, is the most dangerous, because there's somebody waiting in the car, there's somebody here in the room, they mentioned some offhand way, and I believe it's in that high risk. So it really has been shown unfortunately, the only effective intervention is to offer resources in a kind way, even if they're bad and angry with you. And in the emergency department, I encourage all of our nurses to pass this out. If you want to hold them, if they're altered because they're on drugs, keep them all night. We don't have resources at 2 in the morning. We have the conference room. If we don't have space, they can sit in the weight room bed. We can come up, if you work with the provider, we can come up with a reason to keep them safely until we can find resources in the morning. Through, ethical ways of telling them, to stay in the department, whether, hey, it's cold out, or hey, we just want to, this is a 6-hour observation, or provide them a meal, whatever we can. But holding them is, or bringing law enforcement, unfortunately, is usually sometimes the worst thing to do for them. And just, again, same thing with addicts, just continuing offering resources is our best intervention.
And that was a great segue. So I have actually talked about this with our upper administration about what do we do when we're about to discharge and it's 3 o'clock in the morning and I've got 4 hours until I get somebody here. They're okay with us discharging them and then just keeping them there until they get the resources. So we're not kicking them out to the lobby, like just put them in Black Hall or something and make them nice and warm, cozy, give them a sandwich and then just wait it out to the morning.
There's also no criteria to change to be part of a weekend. So they don't have to commit to get out of life to get services. There's certain things they gotta commit to get certain services, but just to be a part of the community and to attend groups, things like that, go to the drop-in, have a shower, get some food, no commitment to change.
Any other questions, comments?
How do you navigate and kind of diffuse the fear surrounding, like, if they have their documents taken from them, or they don't have documents, like, of getting involved in this super
Scary thing.
charged
So,
environment right now?
yeah, so obviously that's a huge issue, right? So if somebody has all of your identification, what can you do to help them to make that fear dissipate a little bit? And that's where our community resources are really the best people to call because they know exactly what to do. I mean, Daisy has explained multiple times to me about how she's kind of helped circumnavigate some of those difficult problems. And like, I can't give them that, but I can give them somebody that probably knows the answer.
Are you talking about something as simple as like how to get their ID back? Or are you talking about
Or
a
if
whole
they
different?
don't, or they've been trafficked from
Undocumented.
Venezuela, yeah, they
Yeah.
don't
Yeah.
have documents.
Yeah,
I mean, that would be really scary.
Yeah,
because
and that's how a lot of them get
Political
bored. I
climate
think
right
we were
now.
just talking about this last week.
And usually when we have cases like that, they usually cross country borders. The FBI usually has gotten involved with those cases, so they've been, they start off with us, but then they're taken to the FBI, and then they give them all of the relocation resources, they help them with the visa application. So for those who are undocumented, they do qualify for special protection visas to stay. So they get all of those resources from the FBI.
I think they actually have to have a case though, don't they, to get the provisions? I think they have to be willing to have a federal case.
Yeah, they do
In
have to
order
be
to get
willing
those.
to have a case
Yeah.
and to work with law enforcement, unfortunately.
Or
I
those
hate
federal
that
provisions.
those,
Yeah.
you know, requirements are on there, but that's the
Yeah.
federal.
If they're local, we have a connection with the DMV in terms of just
getting an
identification.
idea.
That's the easiest thing, is just to replace an identification. The whole package that goes with the rest of it is where the work's at.
But then, well, if within their undocumented, we'll say like if they switch into Mexico, you know, countries that we have seen, the cases that we have seen, are all undocumented folks. So they come here and they don't have, they really don't have anything, and they're not able to get, they can't go to like Catholic Charities and get like a birth certificate. I know Catholic Charities has those services. So I guess I'm just referring more specifically to the undocumented folks that we see. But in either case, our agency is willing to help them if they're not willing to be a part of the federal, you know, investigation. We're still willing to, as the best of us, you know, we're not just doing the legal process, we do the advocacy process as well. So we give them the resources, we connect them to a shelter, we will do whatever we can to help that person be safe. But we just know that they are going to be undocumented for a very, very long time.
Well, and to like also ensure them that they're not gonna be sent back to another unsafe
Right.
situation that they were fleeing from.
That's what I wanted to make sure
That's
that you
what,
knew,
like-
is that you can communicate, and the best thing to do is to connect with one of the service providers, because they'll be able to bridge that gap and get them across that without the fear,
Right,
so that they can make that decision, so,
There's
but
so-
there is options.
yeah.
There's
Take
so
care
many
of them.
people that want to help.
Yeah.
It's like, whatever the problem is, we're like, you know, like, nonprofits get scrappy, man. We are able to
Yeah.
figure some stuff out. You just do it. You figure out, like, what's the problem today? We haven't had that one, let's find a new solution.
Yeah.
I mean, we literally have people in TSA at the airport that help girls get on flights that without identification. And they're going somewhere, they'll vouch for them. It's amazing to see what this community is willing to do.
Once you have the girls and they tell you who it is or what the guy is,
there's a task force within the sheriff's department and all that to try to go after this to stop it, or?
Would you want to take us?
Yeah.
Not at this time. There's no dedicated team for anything like that at this time. That's what we're working to accomplish right now.
There are specific detectives within each law enforcement agency here that they're like our go-tos. So I have a couple business cards, and some of them have specifically said, call my cell number if this is in Sparks territory.
Oh yeah, you guys have a contact that you're willing to call, that's right.
Yeah.
That'd be good, just like Douglas, Carson, and Washoe are all.
So that's a huge thing, right? So like people catch fire on this and they're like, awesome, like Douglas County wants this. And I'm like, great, I don't know resources for Douglas County. It's totally different. So our plan here is for Northern Nevada, Reno, Sparks,
Well, I'm the touch point for the entire
everybody.
state.
Yeah,
For the
she's
entire state.
awesome. My plan is for us.
So I can help with all of that anywhere.
I'll just forward you the emails.
Yeah.
I'm like, I don't know what to do. No.
Right.
Right.
Well, I just want to thank everybody for coming today. This really meant a lot.
Thank you, good job.